at this time. And Dr. Quintero, the floor is yours.
All right, thank you, Patrick, and welcome everyone. This is, I think, our 7th installment of the spring seminar series that is co-sponsored by the Institute of Health and Humanities and the School of Public and Community Health Sciences. Just a quick reminder, we will not be having a seminar next week. We hopefully will be having spring break instead, right? So we will return on March 28th, that's in 2 weeks, when Patrick Lynn will present All That Glitters, Mercury and Gold in the Sahel, results from an educational and appropriate technology intervention to address mercury exposure among residents of 8 artisanal small-scale mining communities in southwestern Senegal. All right, so keep that in mind, folks. But today I am so pleased to be able to introduce Dr. Mimi Nichter. Mimi Nichter is a professor emerita from the University of Arizona and from the School of Anthropology, and has joint appointments in the Norton School of Family and Consumer Services, as well as the College of Public Health there in Tucson. She has conducted longitudinal ethnographic research in a number of areas in South and Southeast Asia and in the US on a number of different topics, primarily related to gender and tobacco use, as well as smoking and drinking among college students, the global marketing of tobacco to women, smoking among low-income pregnant women, and developing smoke-free homes initiatives in India and Indonesia. She's authored a number of books and articles, most recently a book entitled A Filtered Life, Social Media on a College Campus, as well as Lighting Up the Rise of Social Smoking on College Campuses. And today she is going to be talking to us about building capacity for tobacco cessation in Indonesia, from formative research to community-based interventions. Again, thank you so much, Dr. Nichter, Mimi, for being here. It's a real pleasure, and I'll hand the ball off to you.
All right, thank you for inviting me. Thank you for inviting me, although my slides are not advanced. Oh, there we go. Okay. All right, so I'll get right to it. So I'm going to be doing a few things today. First, I'm going to be highlighting the global burden of tobacco, so we get some background into why this is such an important issue. Then I'll explain why cessation is our focus, and by our, I mean this is a very large project in 2 countries, both India and Indonesia. Today, my focus is solely on Indonesia. I'm going to introduce the assumptions of our project, Quit Tobacco International, and what we found in some of our formative research. And then I'll move on to describe the Smoke-Free Homes project in Indonesia. So first, why is tobacco a global health priority? Well, we know that in 2020, tobacco use caused more than 7 million deaths globally. And even though we often focus on a lot of topics like maternal mortality and malaria, childhood diseases, TB, smoking actually kills more people worldwide than all of these combined. So it's quite a huge issue. The global, one minute, I need to move this aside because I can't read my own thing here. Okay, so the global burden of deaths from tobacco has shifted from high-income countries to low and middle-income countries. So whereas in the year 2000, there were 2 million deaths, both in high-income and low and middle-income countries. By 2030, we're going to have 3 million, not only 3 million, but 3 million in high-income countries. But in low and middle-income countries, there'll be 7 million deaths projected. So why is that? Well, as people in high income countries have stopped smoking, the transnational tobacco industry has had to find replacement smokers, and they have gone to the low and middle income countries to do that. And so the uptake of smoking has been going on for quite a long time there. And we see that in the projected deaths. So worldwide, 1 in 4 men, 933 million people are current daily smokers. And 80% of these smokers live in low and middle income countries. And again, this is because people in high income countries have progressively been quitting or dying. An estimated 500 million people will die prematurely from their smoking habit. And in the next decade, tobacco use will surpass all infectious disease, and it's the leading threat of human health worldwide. Also, it's notable that in the statistics that I'm offering to you, it's mostly about men, and that's because in so many countries, including India and Indonesia, it's still inappropriate for women to smoke. So when we think about the century-wide estimates of mortality, they're really overwhelming. In the 20th century, smoking caused an estimated 100 million deaths. But in the 21st century, if people continue to smoke at the same level, smoking will cause approximately 1 billion deaths. But even though these numbers are actually very hard to grasp, hard to get our head around, most of these estimates are really incomplete. They're inadequate. Why? They're inadequate because they're really based just on the smokers, and they don't include the effect of secondhand smoke on those family members. So we have to recognize that morbidity due to tobacco use matters as much as mortality. People who smoke and get ill obviously they don't just die. They're sick for many years, and they're very sick. And often they start becoming sick during the productive years when they're working very hard. And what happens? They can't support their families effectively. So when we think about the sort of the dangers, the risks of smoking, we can't just think about individuals. We really have to think about the economic burden, both to the family and the state. And also that tobacco is a very big risk factor for a lot of chronic disease. So it's not just that people will get some tobacco-related disease, but really it increases the chance of diabetes, for example, and TB. Not only it increases the chance of getting diabetes and TB, and the severity and complications are much greater for people who are smokers. So when we look at mortality or mortality rates and we present information about that, it really glosses over the issue of morbidity and the human suffering that's really experienced before death. Also, those who are smokers are often when they become ill, they're often responsible for their children, for their wives, for elders in their household. So all these people are being impacted as well. So the numerator is larger than just the smoker. It should include many people, and including those who are exposed to secondhand smoke, because they can also get very ill. So all these numbers that I've quoted already, we really have to think about it as really several orders of magnitude bigger. So that we have to think about the direct costs of smoking, and by that I mean not only the direct cost of the illness, but also the direct cost of the cost of actually buying the cigarettes, right? Because that, particularly in low and middle income countries, the money that's spent on buying cigarettes is often taking away from the money for food, to put it quite frankly and simply. And there is evidence of that in studies that have been done in Indonesia. Not to mention, of course, the social and emotional costs of having a parent, a father, as it is in India and Indonesia, who will become ill. So why am I focusing, and why did we study Indonesia? Well, Indonesia has one of the highest rates of smoking in the world. 67% of men smoke, and currently about 4% of women smoke. And it is the fourth largest consumer of tobacco, cigarettes, that is. That is the form that they use, whereas in India, they also use a lot of smokeless tobacco. And Indonesia is the fifth largest producer of tobacco in the world. So some other reasons why Indonesia is a particularly important country to study is that there's a lot of young smokers. Like a third of boys aged 13 to 15 are already smoking. And smoking is very much related to masculinity. So you'll hear people say things, well, if you don't smoke, you're not a man. Some of the global health data from the World Health Organization studies have found that 85% of men smoke in the home. And what are they smoking? They're not smoking your, even though Marlboro is present in Indonesia now, it made a big entry there in the last decade. But most men are smoking Kreteks, which are indigenous clove cigarettes that are actually much worse for health than conventional cigarettes. Why? Because cloves are a kind of anesthetic. And so people are actually inhaling much deeper. And so what's happening is that there's a lot of acute lung infection from those who smoke cloves. And tobacco, one of the reasons tobacco is so important for Indonesia and why they have few restrictions, something I'll turn to in a minute, is because tobacco is the largest source, a very large source of government revenue. So again, why Indonesia? Well, it's also the only country in Southeast Asia that hasn't signed the Framework Convention for Tobacco Control. And so for those of you who don't know what that is, that was the first global health treaty ever put forward by WHO. I think about 180 countries out of the 192 countries that belong to who belong to WHO have signed on to it. The US has never signed on to it because of the power of our tobacco lobby here. But it's an important framework because it does provide for such things as countries that are signatories have to have taxation on tobacco products. They need to ban advertising and promotion. They have to create smoke-free workplaces, etc. So those are important things that Indonesia does not have. So tobacco is aggressively marketed, and I'll be talking about that more in a few minutes. Cigarette prices are very low, and few cities have smoking ordinances. So cessation has been our focus because it's the only means of reducing death in the short term. Prevention would only have a substantial effect on mortality in 2040. And also we believe that cessation efforts actually supports prevention because people see how hard it is to quit smoking, and perhaps that is a deterrent to actually taking it up. Also, we felt that it's a relatively non-controversial toe in the door strategy in countries like India and Indonesia that were in the infancy of tobacco control when we began our project. And we can't assume that, we could not assume that the cessation strategies that we use in developed countries would be applicable to Indonesia. So we had to do a lot of research. So we were focused on not only individuals, as cessation efforts often are, but we were interested in looking at cessation by space. So where people smoked and where they didn't smoke. And we wanted to use science to lobby for smoke-free environments for women and children, because as I've mentioned before, 85% of women are exposed in their home. In India, it's 70%. So we wanted to make it clear that tobacco control was not just an issue for men who smoke, but really a women and children's issue as well. And just a couple of visuals about this. You very commonly you see a man carrying their son or daughter, the man is smoking, or people are traveling in small minibuses, and there's no regulations about smoking inside. And people are trying to hide their children or somehow restrict the impact of smoke on their kids. So our project, QTI, Quit Tobacco International, felt that until doctors addressed tobacco as a serious risk to public health, tobacco use in the population was not going to decline. So obviously doctors can be advocates for telling people not to smoke, but in order for that to happen, the doctors themselves had to quit smoking, and people had to learn about the harm of tobacco. And when we entered Indonesia, which when we started our project, it was about a decade ago, we had two 5-year grants in Indonesia and India. And really, there was almost no information at all about the harm of tobacco being taught in medical schools. So why did we go into medical colleges? Well, we went into medical colleges because, again, to train the next generation of physicians to influence their practice standards. Illness is obviously a teachable moment. And so we felt that they needed to be armed with the proper information. And faculty often have leadership roles, and certainly they're very respected in the community. So in terms of our project, we were in 10 medical schools, 5 in Indonesia and 5 in India. And in each of the QTI medical schools that we were working with, we developed a medical curriculum, which was a kind of a modular, we called it a Lego style approach, because we recognized that we needed to have, instead of having whole classes, for example, on tobacco, we wanted tobacco to be in every part of the medical curriculum. So we wanted the maximum flexibility so professors could put it in wherever they felt it worked. So whether people were learning about reproductive health, whether they were learning about in dermatology, whether they were learning about whatever, respiratory illness, in every component, they would learn about the harm of tobacco to the body. We also developed cessation clinics as demonstration sites, so medical students and healthcare providers could learn how to counsel patients, and the community intervention was largely smoke-free homes. So in terms of the medical curriculum, we had a few goals. One was the full integration of our QTI curriculum across the 4 years of medical college. And it was tailored to the needs of each of the schools that we were working in. Oops. I just missed one. Yeah, so in terms of the formative research, what did we do? Well, one of the things that our baseline data was looking at perceptions of tobacco harm and patterns of use. We wanted to know what people already knew, also what doctors already knew. We also wanted to document some of their baseline cessation efforts and really understand how we could best raise people's consciousness about the harm of tobacco.
Mimi, I think you're muted. Sorry to interrupt. It looks like you're still muted.
Okay. All right, am I okay now?
Yes.
I don't know what happened. Sorry about that. Okay, we also wanted to develop culturally sensitive educational materials and also culturally sensitive approaches to cessation. We found that medical students, when we asked the question about what the prevalence was among doctors and medical students, we found that 18% of medical students were current smokers and 22% of doctors were current smokers. And that number increased across the years of medical school. When we asked about what they thought about the harm of tobacco, 80% of doctors believed that smoking up to 10 cigarettes a day was not harmful for health. So clearly we had 10 cigarettes a day was considered sort of low-level smoking in Indonesia. And so clearly we had a lot of work to do to get people up to begin to recognize that this was really a problem. Smoke, in terms of a layperson's perceptions of, and even general practitioners, their perception of the harm of tobacco. Smoking was associated with lung cancer and COPD, but rarely with other diseases, such as like stroke, diabetes, TB, peripheral vascular disease. People had no idea about that. We've also found that doctors did not ask very much in their general practice. Doctors were not asking their patients about smoking. When we asked doctors, between 50 and 30% of doctors reported that they did so, but when we did exit interviews asking patients, were they asked about their smoking status, the doctor's reports were not confirmed. We also learned that people wanted local statistics about tobacco. They didn't want to know global statistics or national statistics even. They also wanted very specific information on how tobacco caused specific health problems. They didn't want general information. If we were going to tell them that diabetes was bad, they wanted to know how it was bad, what it did to the body. We also found that people really liked graphic visuals. And this, of course, is a very cultural issue. People in different countries will like different things. In Indonesia, they really wanted to see blackened lungs. They wanted to see the arteriosclerosis. They wanted to see the clogging of the arteries. They wanted to know how that affected your body. What was this plaque that developed as a result of smoking? Also, withdrawal symptoms also matter, of course, and they are different depending on different cultures and in keeping with local biology. So in Indonesia, people talked about things that really we hadn't heard before. In this country, one of the main concerns was when they tried to quit, there was a bitterness of the mouth. They talked about feeling very lazy. They couldn't go to work anymore. They felt angry, and emotions are very important. To have a kind of a hold on your emotions is very important, particularly in Javanese culture. And so this really flew in the face of the cultural need to be sort of even and calm. We also found, of course, that quit advice had to be culturally sensitive. People liked, rather than photos, which we thought they might prefer for the kind of posters that were developed, people really wanted to see something that was evocative. So here we see the kids crying over the father who's now sick, too sick to go to work. So now to turn a bit to the community-based intervention and the development of smoke-free homes, because once we started working with the medical schools and the medical students and the doctors, we realized that we really had a much larger population, and that we really needed to focus on the women and children. So I've mentioned before that Indonesia, there's a lot of advertising in Indonesia. Indonesia is not a signatory of the Framework Convention. And so the commonality of advertising in Indonesia is something that I've written quite a bit about, and it really normalizes it. It normalizes smoking behavior, because you really can't walk anywhere in Indonesia without seeing ads. Now, not all the ads are in English, but I've included those so we can kind of get a sense of what they are. You see a lot of advertisements geared towards youth. And these are, women smoking, and also they're for mild cigarettes. So mild cigarettes as sort of starter products, not as harsh as some of the Kreteks that the older men are smoking. And a lot of these are for sponsorship of different kinds of bands and things like that, which is also very prolific in Indonesia. Sponsorship of all kinds of events, be it sports events or even community events, are all sponsored by the industry, which kind of endears them to people. So the ads are quite, clever. Class mild is today's spirit, not just talk only. You shouldn't just talk about smoking, you should actually do it. There's a lot of this mild, emphasis on the mild cigarette for youth. There's also association of modern women, so modernity with smoking. And this is Indonesia is the largest Muslim country in the world, and a lot of women are wearing hijab. They're covered, and so these kinds of ads are, even though there are, of course, there's women like this. We were working in Yogyakarta, which is a large city in the island of Java. And of course, there are women who are dressed like this, especially when they're going out at night, but mostly people are very modest in their dress. But so this is, again, the class mild. Yesterday is gone. Young women smoke. Association with weight control is there as well. And going back to the issue of the importance of being calm, smoking is often promoted as something that helps you diffuse difficult situations. Here's a young woman yelling at her boyfriend, and her words go in as blah, 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 and they come out as LA lights, have a cigarette, diffuse the emotion, feel better for him. Also, a lot of cigarette ads are about nationalism, particularly around the time of elections. And so these cigarettes are also for one nation and for the heritage of, they talk about Kreteks, clove cigarettes, as being the national heritage. So when we made the smoke-free homes, we wanted to, again, make it a women and children's issue. And we wanted to create a movement to restrict smoking inside the home. And we also realized that we needed to come up with steps to make this replicable and scalable. So it would not just be an isolated intervention, but it could be actually a public health movement, because this was really needed in a country where 2/3 of men were smoking. So just a bit now to backtrack a bit about the health effects of secondhand smoke. Women who have never smoked who live with a smoker have a 90% greater risk of heart disease. They have twice the risk of dying from lung cancer. Living with secondhand smoke triggers asthma, bronchitis, pneumonia. Pregnant women who are exposed to secondhand smoke are at much greater risk to preterm delivery, stillbirth, low birth weight baby. And then for children and infants who are exposed, there's also very serious effects. Infants and children are more likely to be born with poor lung function, and also to have asthma, wheezing, and to have them more seriously than other children who are not exposed to tobacco smoke on a regular basis. It also increases the risk of SIDS, can affect physical and brain development. And kids who are exposed to secondhand smoke in the home often have more severe ear infections. And we have to recognize that children are, very vulnerable because they have no control over their environment. And in fact, in Indonesia and in India, the women also have no control over their environment. So at first, to find out more about how women were feeling about this, we conducted a survey in households, 810 households, men and women separately. We also did focus groups with men and women. And we in the focus groups, we focused on the household rules for smoking, what their knowledge base was about the harms of secondhand smoke, and whether or not they would be interested in something like a smoke-free homes initiative. So we found that over 80% in these communities that we were working in had a husband who regularly smoked at home. 85% of households had no rules regarding smoking. Some had rules which allowed smoking in one room of the house, and people thought that was better, where they could close the door or someone could smoke by a window. But most of the houses had no rules for guests because it was considered very impolite to ask somebody, particularly an elder, or anyone from outside of your own household, to not smoke in your home. We also found that a lot of women had already asked their husbands. It wasn't a new issue that we were bringing up. They already hated smoking, but two things. I think one is there was a real fear of women don't tell their husbands what to do. And so it was not something, they could ask him not to smoke, but they really were powerless to make him do anything. And smoking is very acceptable in male culture. So again, that limited what women could say. And however, over 90% of women and 65% of men expressed support for a smoke-free homes policy. And that might seem surprising. I'll talk a bit more about that in a minute. People didn't know very much about the illnesses connected to secondhand smoke. And we quickly learned that people really needed to know about the specific harms as an important first step, because if men had no idea that smoking inside their home was harmful to their families, then why would they want to quit? They wouldn't, right? So they needed to be involved in educational groups about what was really happening when they smoked in their homes. So why did we have a movement rather than sort of individuals? Well, we didn't, a lot of, I think a typical cessation program would be focused on individuals and getting people to quit. However, this was rather doomed to failure. It's very hard to get people to quit over, it's a process. It's a long process to quit smoking, especially when, all your friends are smoking and it's a culturally acceptable behavior. And in fact, it's almost a mandated behavior for men. So we recognized that it was more important perhaps we would have more success with changing community-wide smoking norms inside the home. So we weren't telling men not to smoke. We were telling them not to smoke inside their house. So in Java, there's a high degree of collective efficacy. And by this, I mean, I'm comparing this to self-efficacy. So there, people pretty much buy into the community and group cohesiveness. If others are doing it, then there's a history of campaigns for, malaria campaigns, for example, for getting people on board, for all working together towards eradication of something. So to mount this movement, as I said before, the harms of secondhand smoke needed to be understood, but also positive cultural meanings had to come to be associated with non-smoking practices. Like, what was good about it? So in the beginning, we did presentations to community leaders to try to understand their questions, their concerns. And you can see in these photos that these were separate for men and women, as appropriate in Indonesia, where people really we had an opportunity to tell people what we were planning on developing and getting their input on how it could work. Also recognizing the importance of educational materials, we developed a video on the harms of secondhand smoke. We got a very popular pediatrician to talk about the harms to both women and children. And part of our rationale for doing that was that it was very labor intensive to go to different communities and mount an educational kind of session that people could attend to talk about, secondhand smoke and the harms. And in order for it to be effective, in order for people to come and want to listen, we had to enlist the assistance of popular healthcare providers, doctors, people from the district health office who had some, clout in the villages, in the communities. So we quickly realized that we needed to be able to streamline the process so it could be scaled up. So that's why we worked on developing a video. We also made brochures on how to quit smoking and a variety of stickers, posters, and banners. And this was an iterative process. We refined them continually based on pre-tests that we did. Also, we had educational sessions for the community, and typically, not at this one, this was an early stage that you're looking at the picture, but when we went to the large meetings, there were typically 200 to 400 people from a community would come once we had established our materials and things. We knew what we were talking about. So it was a lot to mount one of these sessions. But the video included information both on the general harms of tobacco, but also specific information for women about women and children and secondhand smoke. Also, people were very interested in understanding that smoke didn't just go away. Once a cigarette was put out, that the smoke still lingered in the air for hours. And we had a machine that we used to show people how much smoke, the toxins that were still in the air, and people were very impressed by that. We also had to explain why smoking in one corner of the house wasn't enough. We also presented the information, going back to the idea that people wanted local information. We presented data on the smoking in their community, what we had learned from our surveys. And also testimonials were included of people who had successfully quit. So why they felt good about themselves. What are community members asked to do as part of this? Well, they were asked not to smoke inside their homes, obviously. They were asked not to smoke at community meetings. That before we began this, it was very typical for people to get cigarettes in exchange for work that they did for the community, like cleaning up the community, or at weddings, cigarettes were distributed. At funerals, they were distributed. At community meetings, etc. So we didn't want that to happen anymore. And we worked very closely with the representatives of the communities who told us what was possible. Right? And we were working with our colleagues at Gadjah Mada University in Yogyakarta. Stickers and posters were posted all around the community. So we found that these stickers were very important. It was very interesting to learn that something as small as a sticker could really have this very powerful impact on this kind of initiative, smoke-free home initiative, because women talked about it helping them, having a sticker on the door. When somebody was about to light a cigarette, they would actually point to the door, or they would move the door back and forth and show them indirectly. So that this is the sticker said this is a smoke-free home. So they didn't have to confront anybody. And also kids made ashtrays that were outside the house. And so people also knew that there was no smoking in the home. Also, there was most of these signs saying, no smoking, don't smoke here, smoke-free community. These were all over the communities. So people who were coming from outside would see them and would come to understand that something was going on here. We engaged community health workers who were very important in monitoring the smoke-free home activities. They were very committed to changing household norms, and they had educational materials to hand out to people. And they felt that that was very important for them to be seen as legitimate, people who were involved with maintaining and creating these secondhand smoke. They were also very useful for us because they could give feedback for us on what was happening on the ground. The declaration meeting, as I said before, were very big meetings, and people made, you can see the declaration, formal declarations they had made up. They had men who were smokers sign pledges that they were not going to smoke in their home, so to sort of make this more formalized. There was media coverage. One of the smoke-free homes community became a model village for health in Indonesia, which kind of upped the ante. We did change social norms. We felt that some men who were smokers began to talk about being ashamed of being seen as smoking inside or outside, very close to their house. So people were proud about to talk about quitting. If someone actually quit after the intervention, they were very proud to talk about it. So again, we were moving from self-efficacy to collective efficacy. And this guy is very proud. He actually quit smoking. This again, so following social norms is a very important ethic in Indonesia. And we developed non-confrontational messages that appealed to male responsibility to care for the health of the family. So we made it, of course, caring for the health of your family was an existing cultural norm. And we built on that in smoke-free homes. And men gain cultural capital for quitting. When men confronted their wives saying, smoking is our culture, they began to confront or say to their husbands, well, what's more important, your smoking or, caring for your family? Is your enjoyment more important than the well-being of the family? And they felt and found that this worked to help the husband think more about quitting inside the house. It also became a school-based movement. A lot of kids who were going to school hated smoking. Young women hated smoking. So we built on their interest. People took it to the primary schools. They had kids made signage, and this signage also went up around the community and in people's houses. Women took to the streets with signs that said things like, please stop smoking, don't smoke here. So they really took it on themselves. 1 year after the introduction of smoke-free homes, we found that the knowledge of harms of tobacco was much higher. They were aware of the harm to pregnant women. Pre-intervention, 89% of male smokers smoked inside the homes of these 4 pilot communities that we surveyed pre and post. And post-intervention, 54% of men smoked inside their home. So this was statistically significant, and we felt like we were on the path to doing this. Like, you have to, of course, it's not as much as we wanted, but we felt like it was a good start. And also that women were becoming more assertive in communicating with their husband about smoking, and they were helped by the posters and stickers. And also guests were also more compliant now because they saw the signage on the street. So in 2018, the last time we were in Indonesia, right before the pandemic, I guess a year before the pandemic, we found that the advertising was as brutal as ever. Here's Suryo Pro, never quit, kind of building on men's physical, whatever activities outside, but just this message, never quit, was really counter to our smoking cessation efforts, clearly. And we found that at one Sunday morning health fair, which is kind of common in this big city of Yogyakarta, not only were they doing sort of health checks and exercise, but also Project Quit Tobacco International, which is still going strong in Indonesia, was there to also promote their booklets about, please don't smoke, quit smoking now. And so now 135 communities out of 600 communities in Yogyakarta have become smoke-free, and the movement is growing. The district health office have taken over the trainings and implementation, and other communities are coming forward to find out how they can also become involved with smoke-free homes. So I'm going to end there and open it up to questions that you might have.
All right, thank you, Mimi. Yeah, so anyone out there have a question, if you wouldn't mind either turning your camera off and unmuting yourself and asking, or if you want to drop a question in the chat, we can do it that way as well. Well, I'll throw a question out there. So, so very interesting work, Mimi. I'm particularly interested in, some of the things you were saying about collective efficacy, and that sort of thing. Really interested in seeing some of the imagery in the advertisements, focusing on nationalism and emotional states. A little bit different than what I'm used to seeing in, let's say, a more North American context. I guess one of the things I was wondering if you wouldn't mind telling us a little bit more about Project Quit Tobacco International. Is that sort of an NGO, or is this part of the health ministry there in Indonesia, that sort of thing?
No, we had two back-to-back and National Institute of Health Fogarty grants. And as you know, Fogarty is the international branch of the NIH. And so the first one, we were looking at sort of developing a curriculum for medical schools. And in the the second one, we were expanding that, and we were working, that's when we did the outreach to 5 medical colleges, working in different regions. Both the projects were in India and Indonesia. So the project was called Project QTI. And again, having our own brand was really important. Developing a brand, that when then we could put on all the stickers, and people had name recognition. And then when the people in Jogja are themselves very media oriented, and they, it wasn't our suggestion. I mean, obviously we were working with people, a group of people from the College of Public Health in Yogyakarta, which is one of the very good medical colleges and schools of public health on the island of Java, which is the biggest island in Indonesia. And people there are extremely creative. There's a lot of art schools in the area, and people really wanted to get involved and wanted to, we were building on something. When we got into smoke-free homes, we were building on something that was almost nascent. There were so many women and children and high school girls and college students who really disliked smoking, but they never had a voice. They never had an appropriate way of expressing their feeling, and somehow we tapped into that. And it really took years. It took years to tap into it, working with a very very visual group of people who are very connected, to different communities, had done many public health projects in that region. So, we use our anthropological skills. We were working with an Indonesian anthropologist and an Indonesian psychologist, public health people. So, yeah, it was a many year. We have been working in Indonesia for at least 12 years. And so this is the medical school itself was a huge undertaking to work in so many medical colleges. And then also we were doing the same thing in India, but of course it worked differently there, right? The same, it just worked completely differently. So I prefer to talk about, the reason I'm talking about this in Indonesia is because by numbers, I think we reached probably more people in India, in South India, where we were working, which is my long-term field area. But in terms of the community involvement, I think there's more sense of community in Indonesia. So it's easier in some ways. Nothing's easy, but easier to develop this kind of smoke-free homes than in a country like India, which has so many communities.
Thanks.
In a community. Yeah.
Thank you. So any other questions out there, Kimber, maybe?
Thanks, Gil, and Mimi, thank you for joining our series and for that really interesting talk. I work another medical anthropologist here, and I work on some on indoor air pollution in Nepal and also in Uganda. But I'm just so intrigued by the relative success in the Indonesian context of these marketing campaigns. And in Uganda, for instance, as a comparator, the reputational cost of being seen smoking, if you're a woman in particular, is so high that I just can't even begin to imagine what campaign would be successful in promoting cigarette smoking there. So I was just so taken by the depiction that you gave us of the success of those campaigns and linking smoking with weight loss and also nationalism is just so strikingly different from the Ugandan setting in particular. One of my graduate students working in Uganda actually she was a smoker, and she said the best way to quit smoking was to go to Uganda, because she would be like, she would think she was going out quietly to have a smoke outdoors and then end up hiding in a bush because someone was coming by, and she was so ashamed. So, so on the shame piece, is that it just, would you want to comment any further on the shame component to being seen to be smoking, or what do you think about that?
Yeah, it's a good question, and I will send a couple of articles to Gil that I've done about smoking and modernity and things like that. You know, it's in Indonesia. They have promoted first. Yeah, I also have an article, an older article now, but it's an article on kind of the advertising in Indonesia. It's brilliant.
Yeah.
It's very big campaigns, and I mean they're marketing the level of smoking and the number of people smoking in Indonesia is so much higher than in a country like Uganda and in most of Africa, actually.
Yeah. Yeah.
So prevalent. And there's no advertising allowed in a lot of countries. And in Indonesia, it's just everywhere. And so in terms of shame, you know, it's really been linked to modernity. And as you could see in those pictures, and there's ever so many more. And there's a lot of young women in the big cities who smoke, and like they're smoking in coffee shops because it's not regulated there. And a lot of the people, actually a lot of the women in NGOs smoke. Because it's really something that you know, if you do it with others, then it I think mitigates the shame or the risk, right? Because you're doing it with a group, you're not doing it alone.
Yeah.
But in India also, India has banned, you know, advertising, but it is very much linked with being a modern woman. And it's one of the things that modern women can do.
Yeah.
And especially in Indonesia where people don't drink, you know, because it's a Muslim country and they don't drink. And so smoking is one of the things you can do. It's not like in India where you can go to a bar too, but then you have the relationship between drinking and smoking.
Yeah.
But we didn't hear, especially among the urban young women, the issue of shame. Whereas in a country like in India, you would feel it more, you would hear it more in the rural area, but among the modern young, no. I mean, it's, but it coexists. It coexists with people who don't want to, marry a smoker, right? Not, of course, but there were medical students, female, women medical students who were smokers, and in fact, in the beginning, we didn't include it on our survey. We were doing the male medical students, not the female, and then it was like, well, wait, we have to know about, because we just made an assumption that women weren't smoking, but in fact they were. So, I mean, I wouldn't say it's very low in both countries, but it's growing.
Fascinating. Well, thank you.
All right. Maybe one more quick question, anybody? Or if not, we have gone past our allotted time. All right. Well, hearing and seeing none, I'll just once again thank you, Mimi, for your presentation and sharing your work with us here today. Really appreciate that. And again, a reminder, we won't be having the seminar next week because of spring break, folks. All right. Thank you.
Thank you.
Thanks again, Mimi.
All right, you're welcome. Thanks for
Take
inviting
care
me.
and tell Mark I said